Welcome back. Today we're going to talk about Chapter 14, which is the secondary assessment. I will let you know right now this is going to be a pretty long chapter. There's a lot of content to this. So if you're coming back and seeing this after our classes discussion, feel free to fast forward to certain areas that you feel like you may not have understood, or just settle in and we'll go through this entire thing together. Do have a lot of topics to cover today. We're going to be covering the secondary assessment, body system examinations, so how we examine the specific body systems, the secondary assessment of a medical patient as well as a trauma patient, your detailed physical exam, reassessments, and we'll touch a little bit on critical thinking and decision making. So like I said, a lot of content to get through today. So we'll start off talking about the secondary assessment as a whole. If you remember, we talked about scene size up, which is the first things we do when we come up on a call. This is how we assure scene safety. We have our BSI. We find out how many patients we're dealing with. The general things that usually you can take care of before you even get to your patient. Your primary assessment comes after that, and that is main goal of that is to identify and treat major life threats. So that's where you find out their baseline mental status, you get their chief complaint, you form your general impression of sick or not sick, and then we focus on our ABCs, and that's our stop and treat zone so that we can stop any life threat that we see happening in front of us. After we do that, we decide if it's a high or low priority patient. That's when we get into our secondary assessment. So that's when we start this. This is at any point, if you're in your secondary assessment and you are reassessing your primaries, so your ABCs, and something goes wrong, stop your secondary assessment immediately and go back into your primary. Just because you've gone through your primary assessment once doesn't mean that you can't go back to it. And as primary and secondary lets you know, anything that happens in the primary trumps anything that happens in the secondary. So just because you're in the secondary assessment doesn't mean that you can't stop and go back to your primary. So what's in our secondary assessment? So primary, we've taken care of our life threats. Secondary is where we get to be a little bit more specific to why are we there. This is the bulk of patient care. If you remember me talking about our scene size up in primary assessment, I said in the most cases of patients and the vast majority of calls we go to, our scene size up in primary assessment in real life application takes 10 to 30 seconds to do. You should be able to knock those things out very quickly in most patients. Their secondary assessment, that is, will take a few minutes on any patient. This is finding out why are we here and treating the specific reason why we're called. So, things that we want to complete in our secondary assessment are your physical examination. You want to get your patient history. So we have two different terms. One is called history of present illness, or HPI. History of present illness, as it reads, is the history of what is going on. So if you have someone who is complaining of chest pain, and the history of present illness would be them saying, well, I sat down after mowing my yard about a half hour ago, and I just got this really big crushing chest pain. It's not really going away, so that's why I called you guys. So that's the history behind what is currently happening. The second type of history that we're looking for is your patient's past medical history, or PMH for short. So a patient's past medical history is things that they have been diagnosed with or experienced in the past. So if you have that same patient who has chest pain after mowing the yard, their past medical history could include they've had several heart attacks in the past, they have high blood pressure, they have high cholesterol, things that will give you more context to is this patient at risk for cardiac events, which that patient would be at great risk of cardiac events. Past medical history can also include things that don't really have to do with what you're seeing today. So you could have someone with a past medical history of they had their gallbladder removed 20 years ago. Does that really have to do with their chest pain they're experiencing today and tell you much about that chest pain? No, but it's important that we know all the different history that the patient has, especially because there's a lot of things that are pertinent to us that patients might not think are pertinent to their chest pain. For example, if they're diabetic, a patient usually doesn't think that their diabetes has anything to do with their chest pain. But we as providers, and we'll discuss it more in medical emergencies, know that having diabetes itself puts you at a higher risk for a cardiac event. So that's why we need to gather the entire medical history and not just, well, do you have any medical history that relates to your chest pain? Because patients don't know what does and what doesn't relate to it. We do. So get all their past medical history and get their history of present illness. The next thing that we're going to be looking at in our secondary assessment are vital signs. We talked about that in the last chapter, chapter 13, how to get your vital signs. So you're looking for your pulse, your respiratory rate, your blood pressure, you're looking at pupils, you're reassessing your mental status. If the patient's warranted, you look at your blood glucose level, you're looking at your oxygen saturation level. Now, all those vital signs that we talked about in chapter 13, we're gathering here. And then we're also looking at signs and symptoms in our secondary assessment. So the difference between a sign and a symptom. Sign is something that you can see. So think of a traffic sign. A traffic sign is something that you can see and something you can read to tell you what's going on. A symptom is something the patient is telling you. So, for example, a sign is you see a patient has a laceration and they are bleeding. That is a sign. You can see that on the body. A symptom would be someone saying that they're having chest pain. If they're having chest pain, I can't visually see their chest hurting. That's something that they have to tell me is happening. That's something that if they don't speak to me, I wouldn't know that they're having this. So, signs and symptoms. Know the difference between those two. And we're going to get talking about reassessment a little bit later. Reassessment is something that we continually want to do of all parts of a call. So your scene size up, you're continually reassessing your scene size up. Make sure that your scene stays safe. Scene size up truly ends at the end of a call. That's the only time that your scene size up truly ends, is once the call is done. Primary assessment, you always have to keep on reassessing primary assessment. Generally, that's pretty easy. If the patient's still talking to you, you keep on reassessing that the patient's airway's open. So that's part of your primary assessment, reassessment. Secondary assessment might have to be a little bit more intentional, but when we're rechecking vital signs, like we talked about in the last chapter, reassessing vital signs, that is reassessing part of your secondary assessment. Asking if the patient's still doing okay, if anything's changed, if their pain's gotten worse, if their pain's gotten better. That's all part of reassessment. So just because we do this once doesn't mean we can stop doing our assessments. So when we are taking our history, so think back to your history of present illness and your past medical history. Well, when we're taking this information in, we have two different mnemonics that we can use to help us get every single thing that we really need to know in our assessment. So the two mnemonics that we use are sample and OPQRSTI. You might hear some people talking about just OPQRST. The I at the end has been added in recent years. It's to cover something called interventions that have already happened. We're going to talk about that in a couple seconds. First, let's go into sample. So sample is a mnemonic that helps us gauge our past medical history a little bit and a lot of our history of present illness. So sample, the S stands for signs and symptoms. So let's go back to our chest pain patient who said that he was mowing the yard and developed chest pain. His signs would be how is he presenting? What do you see? So maybe he has pale skin. That would be a sign that you see. And his symptoms is he's telling you that he has chest pain. So that would be his signs and symptoms. A stands for allergies. Is he allergic to anything? So this person might say, if you say, are you allergic to anything? They might not say anything, or they might list a couple of drugs that they're allergic to. M stands for medications. What type of medications does this patient take? This patient that we're talking about with a significant cardiac history, medications he might be on are daily aspirin. He might be on a medication for his blood pressure. He might be on medication for his high cholesterol that he said he had. So those are medications for M. P is past medical history. And with this P, if we're just doing our focus assessment on the chest pain, we could say past pertinent medical history. So you can ask him what's bothering him, or what type of issues does he have in the past, and how does that relate to what's bothering him today. So he can have the history of the several heart attacks in the past, history of high blood pressure, history of high cholesterol. Maybe he does have a history of diabetes. That's all stuff that's pertinent to you. If he says things like, I have my gallbladder removed, or I've had appendicitis in the past, something that doesn't really relate to cardiac, you want to still be gathering that information, but it's not pertinent to be relaying that to someone else if you're giving a very quick report. If ALS comes on the scene, I want to know, does he have a history of anything related to cardiac? And yes, it's important to write down the other history that he has, but it's not really pertinent to tell it to me in a verbal report where I just want to know very quickly what's going on. So that's P for past medical history or past pertinent medical history. L is for last oral intake, whether that's fluids or liquids or both. So ask him, when's the last time you ate? What was it? This can relate to chest pain, because if he had something that was really spicy and has a history of indigestion, maybe that's part of the cause of his chest pain. Or last oral intake for fluids, is he drinking enough? Was he hydrated enough? Is the heart rate being 140 attributed to your heart being in distress, or is it because he was out mowing for a couple hours and didn't drink anything and he's now really dehydrated, so your body's trying to catch up for being dehydrated? So knowing the last time they ate or drank anything is something that we need to know. And then E is the events leading up to the injury or illness. So for this particular patient, he was mowing his yard. That was the event leading up to this. So he was physically exerting himself before the chest pain started. So that is sample. Signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to the illness or injury. That's sample. So moving on to your OPQRSTI. So this will kind of really focus on the event happening in front of you. So sample is more of the past issues. OPQRSTI focuses on your present illness. So O is for onset. When did this start? So a lot of people confuse onset in the OPQRSTI with the E in sample for events. Onset, I like to say time. What time did this start? So the events would be he was using his push mower, but onset would be he was using his push mower a half hour ago. So the onset was 30 minutes ago. P stands for provocation. That means, does anything make it better? Does anything make it worse? So that is P. Does anything make this chest pain better? You could say, yeah, when I stand up, it gets a lot worse. When I move around, it gets a lot worse. When I sit down, it might get a little bit better. Q is quality. So this is asking, how does this pain feel? Is it a sharp pain? Is it a shooting pain? Is it stabbing? Is it crushing? Is it heavy? Is it dull? So find out what type of pain this feels like. That's Q for quality. R is for radiation. Does it move anywhere? Does this pain stay right in your chest? Does it go into his back? Does it go to the right side? Does it go to his jaw? Does it go to his shoulder? Does it go down his arm? Does it move anywhere? S stands for severity. So on a scale of 1 to 10, how bad does this pain hurt? In the proper medical pain scale, 1 is always or 0 really is the least amount of pain, so that's no pain. And then 10 is the worst pain that you've ever experienced. So the higher you go in the medical pain scale, the worse the pain is. T goes back to time. So O and T can usually be knocked out the same place. So what time exactly did this start? Again, about 30 minutes ago it started. And then I stands for interventions. Have you done anything for this pain yet? Have you taken aspirin on your own? Have you taken Tylenol? Have you done any intervention to treat this pain? This both you can ask the patient And you can also ask someone that you're taking care of from, if that's a fire department that you're taking care of from, or a doctor's office, or any other medical professional. Have you guys done anything to treat this yet? So that's I for interventions. Again, that's kind of a newer addition, but I think that's a very important thing to remember is what has been done already. That way you aren't doubly treating your patient, especially if it comes to medications. If he's already gotten his aspirin for the chest pain, we don't want to double his dose of aspirin. So whenever we are taking anything on our history, we want to be asking open-ended questions. So the two types of questions you can ask are either open-ended or close-ended. Close-ended questions are typically your yes or no. So a close-ended question would be, have you ever felt this pain before? That is yes or no. That is a close-ended question. An open-ended question allows for more elaboration. It doesn't guide the patient to the answer that you want. So you saying, what type of medical problems do you have? That is a open-ended question. Versus, do you have high blood pressure? That is a close-ended question. The reason why we want open-ended questions is it allows our patients to tell us more information. If you ask what medical problems you have, they'll start listing 10 things. If you ask a close-ended of, do you have this? Do you have this? Do you have this? Number one, it usually takes a lot longer to find out that information. And also, we can't ask every single past medical history question out there. We would run out of time. So you, for starters, might not ask every question, and then that might lead to you not getting the information that you need, because you might forget to ask one. You might forget to ask, do you have a history of a heart attack in the past? Which, that's a big one to miss. But usually if you say what type of medical problems you have, they'll lead by saying, oh, I've had 4 heart attacks in the past. I have a really bad heart. My family's had a lot of issues in the past. So try to ask open-ended questions as opposed to closed-ended questions. So when we are doing our physical examination, we have 3 different things we can do. We can observe, so that's what we see. We can auscultate, which is what we can listen to, usually with a stethoscope. And then we can palpate, which means feel. So you can see, you can listen, and you can feel. Those are 3 ways we can assess a patient. All right, so moving into body system examinations. So we're going to kind of walk you through the different types of body systems and some specific things that we want to do while we're assessing those body systems. So the first system we're going to cover is the respiratory system. So if you remember, back in our primary assessment, we look at the respiratory system briefly. So in our A's and our B's, you're looking, is the airway open? Are they breathing adequately? Are they moving air in and out? Do they need oxygen administration? So we're doing a very brief, are they breathing assessment. In secondary, we go much more deeper into the breathing assessment. This is determining, yes, they are breathing, but how well are they breathing? Are they struggling at all? Are there smaller things that we can find and treat to make them breathe better or have less effort of breathing? That being said, the most important thing you need to decide with your respiratory system is going back to your basics and your ABCs. Are they breathing, and are they breathing adequately? Is it effective enough? Is it perfusing the body? If you find in your secondary, when you're taking a closer look, that that's indeed not the case, then go back into your primary treatments of breathing. Go to your oxygen administrations. If you need to, go ahead and ventilate the patient. Breathing status can change quickly, so just because it was okay in your primary doesn't mean it's going to stay okay. So above all, make sure that they are breathing adequately. One of the biggest things that will help you out when you're doing a respiratory assessment is finding out your patient's medical history as it pertains to respiratory cases. 9 times out of 10, if they have a history of some sort of respiratory disease, say they have a history of asthma, it will probably be asthma bothering them again. Usually, anything bothering your respiratory is something that people have been dealing with for a very long time. So if they tell you they have a history of, say, asthma or COPD or pneumonia, anything like that, you should be very suspicious that that is what is bothering them again today. If they do have a history of a respiratory disease, find out, are they prescribed any medications and have they taken it? Most people who, will stick with asthma, most people who are asthmatics have an inhaler and know to use it. So most asthmatics have used their inhaler several times before they resort to calling 911. So find out what they have taken. Again, we need to know what's already in their system so that we don't overdose them on a certain medication. If they do have medications that they've been taking, find out, are they taking it as prescribed? Inhalers, typically it says take 2 puffs every 4 hours. That's how it's prescribed. When someone's having a really bad event, they may have taken 20 puffs in 5 minutes. So find out how much they've been taking and if they are doing it as it's described on their prescription. Also find out, are the prescriptions in date? Some people, again, will stick with asthma. Their asthma might only bother them once every couple years. Your inhaler will expire, so they'll keep it around and they don't feel the need to get a new one because they haven't had an asthma attack in 3 years. And then when they need it, they go and they try to use it and they're breathing in expired medication, which might not be as effective. So find out, is it in date? Are they using it as prescribed? And then find out how this compares to previous events. You can say, so you've had asthma in the past, is this better, worse, or about the same as your normal asthma attacks? And they should be able to tell you. And they might tell you, oh, my asthma gets so bad I have to go to the hospital and they have to intubate me for this, which means put a breathing tube into their lungs, which that is a very significant finding. That means that they get very, very, very bad. Or they might tell you, oh, I get asthma every now and then, and usually my inhaler takes care of it, and it's just not working today. And then you find out that their inhaler is out of date, and then we give them our albuterol, which we'll talk about when and how to give that later on in this course. We give them ours, and then they feel better. And we can assume that they're feeling better because they finally got the in-date effective medication, which typically works for them in the past. So find out what other events like this have been like. And is this worse than those events or better than those events? That will help you predict our treatments and how effective they're going to be. So after we get our history, which again, that will usually tell us a broad sense of what's going on today, you have to go into your physical examination. And this stuff shouldn't look all too unfamiliar to you. This, if you go back to our airway management talks and our primary assessment, these are things that we look at to tell if someone is effectively breathing. This is now where we dive a little bit deeper and find out, okay, yes, they are effectively breathing, but are they struggling at all? So these are some things that will help tell you if they're struggling to breathe or not. The first thing that we look at is mental status. Mental status is one of the first things that we can see changing when someone is not perfusing properly. That's because the brain takes an incredible amount of oxygen to function properly. And if your brain is sensing that we do not have enough oxygen in the system, it's going to start taking from places that use it a lot that don't necessarily need it. And that is our frontal cortex. That's the consciousness centers of our brain. It's going to start pulling from there because your consciousness does not run your body. It's going to want to prioritize your brainstem and other parts of your brain that run your organs and run the rest of your body. It knows that you being able to be fully conscious and alert and know what's going on is not vital to your survival at that point. So it's going to start pulling oxygen from there, and you're not going to be able to function properly. So we are going to see mental status changes. You're going to have someone who has altered mental status. Next, we look at your general level of respiratory distress. Think back to your airway management. Do they have chest retractions? Are they tripoding? Do they look like they're gasping for air? Do they have nasal flaring? Look for all those signs that we talked about in our airway management. Next, look at the chest wall motion. Is it moving just a little bit, so they're taking very short gasps and you aren't really seeing the chest wall go up and down? Are they, on the other side, taking huge gasps for air and you're seeing a lot of movement? Or is it normal movement like you and I do? Next, and this is probably the most important part of your physical examination for a respiratory assessment, is listen to your lung sounds. Your lung sounds will help tell you how air is moving in and out. When we're actually on the ambulance, I tell people one of the first things in your examination you should do after you secure your ABCs is listen to lung sounds, because that will probably tell you what's going on. That, especially combined with history, usually will give you a very clear picture as to what specifically is going on in your respiratory. So listen, and are they clear? Are you hearing wheezes, which wheezes indicate asthma? Are you hearing stridor, which might mean a upper airway obstruction? Do you hear rales, which that's fluid, which might be caused by congestive heart failure? Do you hear rhonchi, which is mucus, which might be caused by pneumonia? So listening to your lung sounds, especially combined with your history, will usually paint a very clear picture as to what's going on. For example, if the patient has asthma, and then you listen to their lungs and you hear wheezes, which you know means bronchoconstriction, which happens in asthma, those two things together point every finger to this is an asthma exacerbation. So lung sounds are huge. Next thing, if you remember back to our vital signs, using your pulse oximetry, measuring how much oxygen is attached to the hemoglobin. So this is a big indication of how is the patient doing. That being said, I will reiterate one more time, pulse oximetry is a wonderful, wonderful, wonderful tool, but it is not the end-all be-all. If it's reading an incredibly low number, but the patient appears to be fine, then think that that number might be inaccurate. If it's reading a high number, but the patient looks like they are struggling, don't neglect to treat the patient. That's why we have this whole list of things on physical examination, and your pulse oximetry is only one. If you have 6 things on here in your exam saying that this person is having a significant respiratory problem, but your pulse oximetry is okay, treat the patient. If you, on the flip side, you have 8 things on this list saying that the patient's okay, but your pulse oximetry is wildly low, think this might not be an accurate reading. So great tool to help back up the case that you've already built with your physical examination. Like I said, in vital signs, typically if someone's pulse oximetry is low, I know it from the rest of my examination before I ever put that probe on the patient's finger. Next thing you want to do is look for edema. Remember, edema means swelling. So look for if they have swelling anywhere in their body. Usually you're looking for swelling in their lower legs. Swelling in their lower legs means that your heart is not pumping as effectively as it should, and that could mean that the right side of the heart is not pumping effectively either and not getting blood to your lungs, or it's putting fluid into your lungs. Next thing you look for is fever. If the patient has a fever, your body's, to maintain homeostasis, wants to breathe a lot more, so it's going to jack up your heart rate, or correction, your respiratory rate. So if you have someone who doesn't have any respiratory history, and the rest of your respiratory assessment says that they're moving good air, their chest wall is moving good, their lung sounds are clear, but you see that their respiratory rate is elevated, it could be just because they have a fever. And the next thing you look for is their skin condition. If you have someone who is in true respiratory distress, your body is sensing that somehow you are not getting enough oxygen and carbon dioxide moving around, so it's going to be sensing that you're hypoperfusing. Another word for hypoperfusing is shock. So if your body notices that you are hypoperfusing or going into shock, it's going to go into self-preservation mode. That means that it's going to be pulling blood to its core. You want to be perfusing with what little oxygen you have, your vital organs. As I've said before, you can live without a hand. You can live without an arm. Your body knows this. You can't live without your liver. You can't live without your lungs. You can't live without your heart. Your body knows this. So your body will shunt all the blood to your core and not have much in your arms or your legs, which means it's not going to be close to the skin. If you don't have blood circulating near the skin, it's going to turn pale because blood gives your skin its color. So you're going to look pale. If you don't have blood circulating near your skin, it's going to be cold because the blood is what gives the skin its warmth. And then when you have no blood circulating around, your sweat glands are going to release. So someone with respiratory distress, you're going to see pale, cold, and clammy skin or diaphoretic skin. So a lot of patients, you can see that as you're walking up to them. A lot of these secondary assessment things, for especially respiratory, you can see from a distance. That helps form your general impression. If you walk up and you see someone who is tripoding, looks like they're gasping for air, and they have cold, diaphoretic, and cold, or you can't assess cold from a distance, but they have pale and diaphoretic skin, you can tell from that distance that they are in some sort of distress. That goes into your general impression of sick or not sick. You know that they're sick. You know that they're having a respiratory thing. So a lot of these assessments you see immediately in your general impression, and then you dive a little bit deeper into looking at them more closely after we secure that our ABCs are actually intact. So now we're going to move into our cardiovascular system. Remember, cardiovascular system consists of your heart, your blood vessels, and the blood itself. So keep in mind, when we're talking about cardiovascular system, all three of those go into account. If anything goes wrong in any one of those three, you're going to have a failure in your cardiovascular system. So again, the first thing that we want to be looking at is your specific history as it relates to your cardiovascular system. So find out, do you have any existing cardiac conditions? Have you had a heart attack in the past? Do you take any medications for these conditions? A lot of times patients, when they're prescribed a medication, they suddenly think that they are healed. So you'll say, do you have any medical problems? Oh, no, I don't. Okay, what medications do you take? Well, I take 3 medications for blood pressure. They don't think that they have an issue with their blood pressure because they take medication for it. So they think the problem's solved. So it's not part of their medical history, when in fact they have a history of high blood pressure. So find out their conditions and their medications that they take, and look at different diagnoses that might not be, I've had a heart attack in the past, but might be risk factors for heart attacks. So high blood pressure is a risk factor for a cardiac event. High cholesterol is a risk factor for cardiac events. Having diabetes is a risk factor for cardiac events. So we'll discuss this all in cardiovascular emergencies, but knowing the different things that put you more at risk. Also knowing personal habits. Are they a smoker? Everyone knows that smoking puts you at higher risk for cardiac events. Do they use drugs or have a history of using illegal drugs? That can put you at a risk of having a cardiac event, especially if you have someone who is complaining of dizziness and you find out that their heart rate is 200, then you find out that they are a frequent cocaine user and they use cocaine today. Cocaine makes your heart go very fast. So that can help explain why their heart is going fast today. So finding that stuff out, and then dive a little bit into their family history. Does their family have any history of heart attacks? A lot of people might say, they're 35 years old, which seems to be a young age for any cardiac event, but their father died at 40 from a massive heart attack. Their grandfather died at 38 from a massive heart attack. Family history goes a long way in showing you what might happen to you. So sorry for anyone who's listening to this who has a family history of people having massive cardiac events, especially early on. Typically, if your family has a history of it, it's probably going to happen to you as well. The heart follows genetics pretty closely. That's why when you go to the doctor, they ask you, are your parents or grandparents still alive? How much health are they in? Have they ever had heart attacks? Have they ever had strokes? Because that will go a great way in telling you how at risk you are for this stuff. So finding out family history is huge. Then go into your specific signs and symptoms of this episode. This is where your OPQRSTI and as well as your sample goes a long way. Find out the specifics of what you're seeing. Also determine the specific characteristics of that pain. So instead of saying, does anything make it better, anything make it worse, you can say that, but then dive in deeper. Palpate the chest. When you're palpating it, does it make it better? Does it make it worse? When they get up and move around, does it make it better? Does it make it worse? When you take a deep breath in, does it make it better? Does it make it worse? Especially chest pain, you've got your lungs and your heart there, both of which can cause pain. Or you can also have your esophagus there. That can cause pain. So you got a lot of things in your chest that can cause pain. It might not be part of your cardiovascular system. So find out the specific characteristics of the pain that you are seeing. So we're going into your actual physical examination. Look for signs that the condition might be severe. We covered this for hours with pathophysiology. So look for signs that your body is not moving blood around effectively. It's not perfusing effectively. Some of the biggest signs that we see there are your skin condition. Is it pale? Is it diaphoretic? Is it cool? Same things you look for with your respiratory. That will go a long way in telling you, are you perfusing correctly? Other signs that condition might be severe are your vitals. So you need to obtain your pulse. You need to obtain your blood pressure. When you look at a cardiac patient, their heart might be pumping either really fast or really slow. That might be a sign that whatever's going on will be severe. Also blood pressure. It might be very high or it might be very, very low. So those are signs that the condition might be more severe. Note your pulse pressure. So pulse pressure, that's a new term for you guys. And pulse pressure is the difference between your systolic and your diastolic blood pressure. So if you take your systolic blood pressure and you subtract your diastolic blood pressure, that gives you your pulse pressure. That number means whenever your heart contracts, that's the amount of force that's actually being pushed out. That's how hard it's actually contracting. So if you have a blood pressure of 120/80, your pulse pressure is 40. 40 millimeters of mercury is how hard the heart is actually contracting every time, because you have your baseline pressure in your system already. That's the added pressure you put in there. If your systolic is 120 or diastolic is 110, your pulse pressure is only 10, which that means that your heart is barely putting out any blood or any force when it contracts. That's an issue. So note if you have a small pulse pressure, or if you have a very large pulse pressure, that could mean that your heart is pumping way too hard. So if your systolic is 200 and your diastolic is 60, your pulse pressure is 140. That means that your heart is pumping very, very, very hard every single time. Next thing that you look for is jugular vein distension. So we're going to talk about that a little bit more in trauma, but your jugular vein is what runs in your neck, and when it bulges out, that usually indicates, because your jugular vein feeds into your superior vena cava, that means it can't drain into your superior vena cava as well, and the only reason why that should happen is if your superior vena cava can't drain into your right atrium as well. There's a backflow problem, so you can't push more blood in there because your heart's not accepting it. That means your heart's not performing the way it should because it can't accept as much blood inside of it. So you're going to start to see your jugular veins pop out because they're filled with more blood than they should be. So seeing jugular vein distension, or JVD for short, could be a sign that you have something seriously wrong with your heart. Next thing you want to do is palpate the chest. Find out, is this pain reproducible? Like, can you make it worse when you palpate the chest? Typically, and we'll talk about this more in cardiovascular emergencies, typically when you palpate the chest, if it hurts more when you palpate it, that chest pain will typically be a cause that's something more musculoskeletal. So it might be the muscles inside your actual chest and not your heart causing the pain. Typically. Just because the chest pain gets worse when you palpate around does not mean that it's not cardiac related. It's just a sign that it might not be. Look at their posture and their breathing status. Usually, if your cardiovascular system goes down, your body will want to compensate. Again, remember pathophysiology. You want to maintain the same amount of perfused blood circulating around. And so if your body senses that your blood is not moving enough oxygen around, it's going to jack your breathing up because it thinks, oh, we need to get more oxygen into our body. When in fact, it might be your heart's not circulating that oxygen as well. So you might see someone with difficulty breathing because your body's trying to compensate for not moving enough blood around. Also look at their posture. Remember we talked about Levine sign? That's where you take your right arm and you kind of put it over your left chest and grab your left shoulder. That is a instinctive reaction to chest pain. So look at their posture, look how they're breathing. And then again, look at their skin condition and color. If you are not circulating blood well, it's going to look just like it does if you aren't breathing well. Breathing and or respiratory and cardiovascular go hand in hand in terms of how the body kind of responds to threats to those areas. It's going to want to circulate more blood. It's going to want to preserve the blood to the core. So you're going to be seeing your cold, diaphoretic, and pale skin. So we touched on this a little bit in the last couple slides, but does all chest pain mean that's a cardiovascular event? No. Chest pain can be caused by several different things. It could be something going on in the lungs. It could be something going on in the heart. It could be something going on with your esophagus. It could be something going on with your skin. It could be something going on with the muscles underneath your skin. It could be something going on with your ribs. It could be caused by several different factors. That being said, we in medicine have to think that's the worst possible scenario until it's proven otherwise. The only way to prove definitively that it's not a cardiovascular event is with blood work. We do not do blood work on the ambulance. So we always have to assume that chest pain is the result of a cardiovascular event until proven otherwise. That being said, if you have every sign leading to it not being a cardiovascular event, your suspicion can be very low. You might only have a 1% suspicion that it's a cardiovascular event, such as you have someone who's complaining of pain on the far right side of their chest, that when you push on it, it is very reproducible on that pain. It hurts a lot more when they take a deep breath. You're thinking it probably has something to do with the ribs or the lungs on the right side. But we can't just definitively say that there's nothing going on with your heart. They need to be brought to the hospital for further evaluation. We can't give them a clean bill of health saying, yes, this has nothing to do with your heart. We don't think it does. The chances are incredibly low, but we don't have the tools available to tell with 100% certainty that it's not. So keep that in mind. All these assessment tools will help you raise or lower your suspicion of a cardiovascular event, but we don't have the technology available to us in the field to say with 100% certainty that something related to the chest is not cardiac related. So moving on into your nervous system. Nervous system, the biggest things we see that we can assess is your mental status, the ability to control movements or feel sensations, and signs of dysfunction somewhere in the body. So those are things that the nervous system controls that we can see. So when we're assessing our neurologic systems, 3 things that we need to do. First and foremost, we need to find out what is the patient's mental status right now. You might remember this from our primary assessment. Primary assessment, remember AVPU. AVPU standing for being alert or alert to verbal, painful, or unresponsive. If they're alert, you need to know if they're alert and oriented. So are they oriented to person, place, time, and events? If someone is alert and oriented to all 4 of those areas, they won't have altered mental status. If they answer any of those questions related to person, place, time, or events wrong, they have altered mental status. So that will tell us or give us a good picture of how is their brain functioning right now. Is it normal or is it altered? When you find this out, if you see deficits or if you see any differences, find out what is their normal state of mental functioning. Not everyone at baseline is alert and oriented. Some people for the entire lives, will be altered. So find out, is this normal for them? And if their normal is not the typical normal, find out, have they changed from their normal baseline today? Next thing that you want to do is, again, obtain the history of neurologic conditions. So do they have a history of strokes? Do they have a history of any other cognitive issues? History will first tell you if they're at risk for another event. So if someone's had 3 strokes in the past, then they're at risk for having another stroke right now. Also, it will help you think, do they have any deficits from previous neurologic emergencies? So sticking with stroke, if someone has a stroke, find out, did that stroke permanently mean that their left hand doesn't work well anymore? That way, when you're fully assessing them and you see that the left hand's not working, you know, well, that's normal for them. That's not a change from today. So you aren't worried about that nearly as much. Next thing you do is note the patient's speech. Are they slurring their words? Are they seem like they have a hard time coming up with words? Are they talking really, really slow? Find out and compare it to their normal. Are they talking normally? If you have an indication that they have anything wrong with their neurologic assessment, you want to perform a stroke scale. The 2 different types of stroke scales that we have are called the Cincinnati Pre-Hospital Stroke Scale. We also have the FAST ED Stroke Scale. We'll talk about that a lot more in neurologic emergencies of how to actually perform those stroke scales. So we need to find out, are they having a stroke? These scales will help us determine if the likelihood is high or low that they're having a stroke. Check their arms and their legs. Are they moving normally? Do they have normal sensation? Do they feel numb somewhere? Are they having trouble moving something? If they're having trouble moving something, always think it's a nerve issue causing trouble moving. You can't get the signal to the leg to move. Palpate your spine, and especially the C-spine area. Make sure that you don't have any trauma to that area. Make sure that you don't have any step-offs or anything abnormal about the spine, because again, your spine houses your spinal cord, which then transmits all the nerve signals. Check your extremity strength. So check to see if you're weak, especially on one side versus the other. Or if someone is weak, find out, is that weakness normal? If the person's always a little weak in that area, especially in our elderly population, then that's not as significant of a finding as a 20-year-old who is usually healthy and suddenly is having a really hard time moving their legs. Check the patient's pupils. Pupils are controlled by your brain. So if you're having an issue with your brain, you're going to see that very quickly in your pupils. So check for their size. Are they normal size? Are they dilated? Are they constricted? If you see dilated or constricted pupils, a lot of times you're going to see that in a neurologic event, and it's going to be caused by something that's also causing altered mental status. Are they equal in size? Are they reactive to light? Any finding that is not normal for pupils, you have to think something is going on in the brain. So those are all some things that you need to look at for your neurologic assessment. So moving on into the endocrine system. The endocrine system, if you remember, endocrine is mainly hormones. So it's the hormone system in our body. And one of the major and most common ways that we see the endocrine system malfunctioning is in diabetics. In diabetics, your pancreas fails to secrete insulin, either enough of it or any of it. So the most common endocrine system disorder that we encounter in the emergency setting is the diabetic patient. There are plenty of other endocrine disorders out there, but typically we don't see them in emergency settings. Typically, there are a few instances, but usually if it's an endocrine system emergency, it's going to be something related to diabetes. So that being said, again, we start with our history. For pretty much most of our focus assessment, history is going to tell us a lot. So if they have a history of diabetes, expect your glucose levels to be a little bit off, especially if you have a history of diabetes with altered mental status. That's one of the first signs of blood sugar levels being either too low or too high is altered mentation. And diabetics are almost always on some sort of medication to control their diabetes, whether that's a pill or injectable insulin itself. Depends on what type of diabetes you have. We're going to discuss that in our endocrine lecture. So find out what medications they have and have they been taking them properly. A lot of diabetics don't take their medications as prescribed. They are a very big group of people that we call non-compliant with their medications, which means that they don't take them as prescribed. Usually they don't take them at all, which will then throw their blood sugar levels off quite a bit. Some specific things that you want to know about diabetics is what have they been eating lately? How frequently have they been eating? When was their last meal? Because eating is how we take in blood sugar or blood glucose. So if they haven't been eating, their blood glucose levels will be lower typically. Also find out, have they been exerting energy? If they've been exercising, we have a greater demand of glucose in our body to make ATP for the energy to do whatever activity we're doing. So you burn through your glucose a lot quicker. So if you have a diabetic who hasn't eaten much, so they don't have much intake of glucose, and they've been using a lot of glucose, it can combine and result in a very low blood glucose level. Another thing you want to think about is the patient sick? When you're sick, your body, even though you are going to be resting, your body is working double or triple time. So all the cells are using a lot more ATP. ATP, again, uses glucose to make energy. So even though you aren't going to be moving around and having a lot of energy and exerting a lot, your cells are, and so you're going to be burning through a lot more glucose. So knowing whether the patient's sick or not can help you determine if this is a major endocrine problem or not. And then also find out if the patient has taken blood glucose to help get the levels up. So that could make the patient's levels a little too high, or if they use an insulin pump. Some people have an insulin pump that will constantly pump insulin into their body because their pancreas is not producing any of it. So if you have someone who has low blood sugar to start with, and then they have an insulin pump that keeps on pumping insulin in, it's just going to make the problem worse and worse and worse. And we're going to need to stop that pump from actually pumping. So knowing that if they have a pump and being able to stop it if the patient has low blood sugar levels is a critical thing to do. When we're coming into the physical exam, the first thing you want to look at is the patient's mental status. Like I said, that's usually the first sign we see for a blood sugar problem is the patient's mental status. Observe the patient's skin. Just like with most of our other examinations, if the body's in distress, your skin becomes pale, clammy, or diaphoretic and cold. So if you see that in a patient that you're suspecting an endocrine emergency, that usually is a sign that there's a significant emergency going on. Obtain your blood glucose level. That's one of our basic vital signs that hopefully your agency is allowed to do, and that will give us an exact number to tell us what is happening in the body. Also, when you're doing your physical exam, goes hand in hand with history, look to see if there is an insulin pump in the patient's body. Usually it's attached to pants, and then you'll see there's a wire that goes into a part usually in their abdomen that's injected, and you have insulin go from the pump through that little tube into the patient's body. So look to see if you have that there. Moving into your gastrointestinal system. So that's your GI for food and digestion. When we are looking at our GI system, look at what's coming in and what's going out. Again, we want to start with our history. Find out, do they have a history of gastrointestinal issues? A lot of the time, if they have a history of a GI problem, it's going to be a repeat issue. Me personally, I have a history of chronic pancreatitis. Pancreatitis gives you a significant amount of abdominal pain. We'll talk about it in our abdominal emergencies lecture. But I know that if I have a major amount of abdominal pain, it's a almost guarantee that it's a issue with pancreatitis. So when I go into the hospital, I can say, I have pancreatitis, that's probably the cause of this pain. They then draw labs to confirm it, and it's almost always the cause. So that's not a unique thing about me. If someone has a diagnosed GI issue, and they're experiencing pain again, chances are it's going to be the same issue, especially if it's presenting the same way. So history goes a long way to telling you what might be going on. Some other things that you want to be looking at is the oral intake, the frequency of it. Sometimes people are not eating at all. Sometimes they're eating too much. And find out what types of food it is. Some types of food bother the GI system at baseline. Find out how much pain they're in. That's one of the biggest things. So using your OPQRSTI in your sample is huge for a gastrointestinal assessment. Find out if they're vomiting. If they're vomiting, find out how frequently they're vomiting. What does it look like? Is there any blood in it? Also, on the other end, ask about their bowel movements. Are they having bowel movements? Are they of normal frequency for them? And find out what is normal for them. Some people, it's normal to have 3 to 4 bowel movements a day. Some people, it's normal to have 1 bowel movement every 3 to 4 days. So find out what's normal for them. So find out frequency and the consistency. The normal consistency of bowel movements should be together but loose. So it should be a formed feces, but it shouldn't be very hard and compacted. So find out what their normal consistency is, and then find out if this is varying. If they're having diarrhea, that's a very significant finding for a GI assessment. Also, find out, is there blood in the bowel movements? And if there is blood, find out what color it looks like. If it's bright red blood, we know that that's a bleed happening in the lower abdominal tract, usually near the rectum. But if it's a black, tarry, sticky substance, that means that that's blood that's been digested by acids. So you have an upper GI bleed, which is usually much more significant. So, and again, we're going to cover this all in abdominal emergencies. But these are questions that you need to be thinking about in your assessment. As far as your physical examination of a GI patient, you want to find or observe what position they're in. What's a position of comfort for their pain? Because most of our GI patients are in some sort of abdominal pain. So find out what's comfortable for them. When you assess the abdomen, you want to be feeling around the abdomen. Feel if areas are tender. Feel if there's something called rebound tenderness. So it hurts a lot more when you, after you push in, when you release, it hurts a lot more. That's usually a sign of appendicitis. Find out if it's rigid. Like if you feel and it's soft, that's what we should be feeling. But if you feel and it's really hard or distended, that's a problem. You can see if they're guarding the area. So if you go to touch it and they immediately try to guard their stomach away from your touch, that's a significant finding, and it usually tells you that the patient's in a significant amount of pain. Also, inspect the other parts of the GI system. So take a look at their mouth. Make sure that you don't see any bleeding or anything lodged in there. Usually you don't have to inspect the anus, but you can ask them questions about it if it's bothering them. Moving on into our immune system. For emergencies, just like with the endocrine system, our most common emergency is diabetes. Immune system, our most common emergency is allergic reactions. So that's the most common thing we see with our immune system that we as EMS providers have to fully assess and treat. So we have the term allergic reaction, and we have the term anaphylaxis. Now there is a difference between these two terms. So an allergic reaction is a reaction that your body has to an allergen. A lot of people have allergic reactions all the time and are fine. Anaphylaxis, on the other hand, is a form of shock. So anaphylaxis, by pure definition, is an allergic reaction that is affecting 2 or more body systems. That means that you've moved from just a simple allergic reaction to anaphylaxis. Okay? So a mild allergic reaction might be someone has allergies to pollen, so you get a runny nose, so it's affecting your respiratory system. But you're not usually affecting your cardiovascular system when you have pollen allergies. Anaphylaxis, on the other hand, if someone is severely allergic to a bee sting, so they get stung, you have difficulty breathing, and then your heart also speeds up, and your blood pressure goes down, so you're affecting your respiratory and cardiovascular system, and your skin starts to swell, so you're affecting your integumentary system. So that altogether means that you are in a state of anaphylaxis. Anaphylaxis is something that we have to treat immediately because it can turn into a very, very deadly form of shock. So when we're assessing people with immune system emergencies, typically people with allergic reactions, find out if they are allergic to anything that they know about. If they are allergic to something, find out if they've had exposure to it. So if they are allergic to bees, find out, were you stung by a bee? If they have an allergy to peanuts, find out, were you in any environment that you may have encountered peanuts or peanut dust? If they do have a history of an allergy, find out, what is your normal reaction like, and is this like your normal reaction? Sometimes this might be a reaction to a completely new source, but if they have a history of the allergy and they've been exposed to the allergen, usually their history will tell you how severe they're going to get. So if they have a history of allergic reactions to bee stings, and they just have a scratchy throat after they have a bee sting, but then they get better, and this is the only time that, or only reactions that they've ever had is that, typically these people aren't going to have their throat completely close up and stop breathing on you. Typically. That doesn't mean that's going to always be the case. But if someone on the flip side says that they have a allergy to bee stings, and whenever they get stung by a bee, their throat does close up, they stop breathing, their blood pressure goes down, they have to go to the hospital, and they are incredibly sick, expect that to happen, even if they aren't presenting like that right now. So have your index of suspicion be much, much, much higher that that's going to happen. Also find out if they have an EpiPen. And if they have an EpiPen, have they taken the EpiPen? That's a very significant finding for us because we don't want to give them a double dose of Epi if it's not needed. Because Epi, if you give too much, has very serious side effects on the body. We will talk about that a lot more in our immune system lecture and in pharmacology. Symptoms that you need to look for are tightness in your chest and your throat, some difficulty breathing. Listen to lung sounds, and I always say to listen to throat sounds too. So put the bell of your stethoscope on the throat and listen to the trachea, because stridor, which is the noise that you might hear in allergic reactions, is much more prevalent up in the throat because it's an upper airway sound. So listen to throat sounds as well. When you're going into your physical examination, if they had a point of contact with the allergen, which most people will, unless if you ingested the allergen, find where that point of contact was and take a look at it. If they were stung by a bee, take a look at the bee sting, see how the immediate area is looking. If they are allergic to some ingredient in a laundry detergent and they put clothes on that had that detergent used, look where the clothes were. See what that area is looking like, because that usually is the area with the most allergen in it. Look all over the patient's skin for hives. You especially want to be looking at hives on like the chest, on the back, near the throat. You also want to be looking at the face, lips, and mouth. You want to be making sure that the swelling is under control, that we're not occluding our airway, because that will result in an issue with our primary assessment. And listen to your lung sounds and throat sounds. So moving on into our musculoskeletal system. When it comes to our musculoskeletal system, there are some medical diseases to that system but they are relatively rare. We don't run into these all the time. When we're assessing things in the musculoskeletal system, make sure that you assess the bones. A perfect example is I once had a patient that had a lesion on her femur, and so that's an issue with the musculoskeletal system. And she had some leg pain and pain up in there, was walking around just fine, and in the middle of the call, we moved her leg maybe an inch, and her femur just completely snapped. That's not something that should happen in a normal person, but someone with a lesion on their femur has a very brittle femur, and it's with all the tendons pulling on it already, the smallest movement can make it snap, and that femur really went quickly. So knowing what diseases they have and then paying close attention to the bones is something that we really need to have concern of when we're assessing our musculoskeletal system. Again, look at history, so find out their prior injuries that they may have had. If they say that they have a condition where their bones are very brittle and they've broken 20 bones in their lifetime, be much more or suspect a fracture much more higher than you would in most other people, especially with very mild trauma or sometimes no trauma at all. Find out if they're taking blood thinning medication. So blood thinners can cause internal bleeding and have it be much, much worse than most people because your blood can't clot nearly as effectively. And also use your history to find out if a medical problem caused a traumatic injury. So again, the broken femur is a traumatic injury, but that was caused by a medical problem. Just literally lifting the leg up an inch is not a traumatic cause of this traumatic injury. It was having a lesion on the femur that was the cause of the injury. So when you're doing your physical examination, look for signs of injury. So again, with this femur patient that I brought up, once that femur actually broke, there was a huge deformity in that area. You could see that there was a broken bone inside of there. Palpate the areas that you might suspect injury to. So feel around, see if there's any tenderness there when you're touching. Look to the other side, see if it's an injury to the leg, see if the right leg looks like the left leg, or if there's differences in there. If the right leg is shorter than the left leg, that's usually a sign that something's happened. When you're palpating, feel for something called crepitus, which we'll cover a little bit later. Crepitus is the feeling of bone fragments rubbing together. And if you have a patient that has multiple injuries or if the patient is unresponsive, make sure that you do a full assessment of the patient. We call this a head-to-toe assessment of the patient. Anyone who is unresponsive, you should always do a head-to-toe relatively quickly. And people who are responsive to you, you're still doing a head-to-toe, but it's much less invasive because they can usually tell you complaints. So you're still assessing the patient from head to toe, but we probably aren't putting hands on certain areas. If you have someone who's called because they have tooth pain, you palpating down their legs is not really something that we have to do. Take a look, make sure that you don't see anything wrong with the legs, but they might be questioning you if you're palpating down their legs when they just called for tooth pain. So moving on into the full secondary assessment of a medical patient. A lot of this is going to be kind of a review of what we already went over. When we have a responsive medical patient, that's when we focus on our chief complaint and our symptoms that people are telling us. If they say, I have chest pain, focus on the chest. That's where you should be putting most of your effort into, is what they are complaining of. If they're unresponsive, focus on what you are finding. So you want to do that head-to-toe assessment of the patient and focus on the abnormal things that you find. So if you see an unresponsive patient who has cool, clammy, pale skin, and you are doing your head-to-toe and you see that they have an insulin pump, start thinking that this patient might have low blood sugar and start assessing the endocrine system a little bit heavier. So go off of what you are finding. If you have an unresponsive patient and you are looking at their eyes and you notice their pupils are constricted, think that this might be a neurologic issue and think of what might affect your neurologic state, such as drug use. So when they're responsive, we can be a little bit more limited and we can really focus in on what they're telling us, but you have to rely on your full assessment skills if they are unresponsive. So assuming that our patient is responsive, you again want to learn your history of present illness. You want to learn their past medical history. You want to do your physical exam and focus in on the area that they are complaining about. Obtain your baseline set of vital signs. And then, once our assessment is completely over, you want to administer interventions that you deem appropriate for what you found, and then transport the patient to the hospital for further evaluation and care. Again, with our history of present illness, you want to be asking open-ended questions. This allows for a lot more information to be exchanged. Our primary source that we want to obtain our history of present illness from is the patient. There are instances where the patient is not a good historian for us, whether that's someone who has altered mental status, or maybe it's a child, or it's someone who has a medical diagnosis that makes it hard to communicate, or maybe there's a language barrier. The patient only speaks Spanish. So in those events, try to obtain your history of present illness from family members or bystanders who saw an event happen. So again, we're going to be focusing around the chief complaint. The chief complaint is actually obtained in our primary assessment. That's one of the things that we obtain before we go into our ABCs. And chief complaint should tell us why we were called. And it should help us focus on what's bothering the patient the most. Just because a patient has a chief complaint doesn't mean that they don't have multiple complaints. So you can't just focus on only the chief complaint. You have to focus on all of them. Just pay a little bit more attention first to the chief complaint. Example of this is someone might be having chest pain, and that chest pain is causing them to have difficulty breathing. So you have to look at your cardiovascular system. You also have to look at your respiratory system. So you're assessing two systems at the same time there. So chief complaint is very important, but don't neglect to assess the rest of the patient just because of their chief complaint. And know that you might have more than one system involved. Again, we want to be using our OPQRSTI method. So O stands for onset, P for provocation, Q for quality, R for radiation, S for severity, T for time, and I for interventions. If you need more explanation of those, go back to the beginning of this chapter. Remember your sample mnemonic. So S for symptoms, A for allergies, M for medications, P for pertinent past history, L for last oral intake, and E for events leading to an illness. So when you are doing your physical exam, you want to tailor it to be more specific to the patient's chief complaint. So if you have a chief complaint of chest pain, tailor your physical exam to the cardiovascular things. So remember back to when we discussed cardiovascular emergencies and how to assess that. So tailor more towards the risk factors for cardiovascular disease, like the high blood pressure, high cholesterol. Ask about the family history. If you have someone who has abdominal pain, if they have family history of heart disease going back 2-3 generations, that's not nearly as important for abdominal pain as it is for someone who has chest pain. So tailor it more towards whatever chief complaint you see. That's why we have the different types of assessments for different types of body systems. That way we can become much more focused in on our specific chief complaint. Again, when you're talking with pediatrics, remember this from Lifespan Development, get on the same level with the child. Go eye to eye with them. Don't be towering over them. Try to put questions in very simple language they can understand. Don't use complex language that they might not be able to answer accurately. And also talk with their parents. Get a lot of information from the parents. Parents are very, very, very valuable tools when it comes to dealing with pediatrics. When you perform your physical exam, it's usually relatively brief. The time that you actually put hands on the patient, it's usually pretty brief. And it's usually based off of the area that they have their chief complaint about. So if you have a patient that has a chief complaint of, we'll bring up tooth pain, you're not going to be palpating the stomach nearly as much as you would if they had a complaint of abdominal pain. So try to focus in your physical exam on the area of concern. They have chest pain. You're going to be doing a lot more of your physical exam focused on the chest region than you would down on the lower body for the musculoskeletal of, say, the lower leg. So tailor it to the area we are focusing on based off of our complaints. Going back to the last chapter, it's essential to obtain a baseline set of vital signs because your later sets of vital signs, your repeat vital signs, are going to be used to compare against this to trend how the patient is doing. So remember, your first set is your baseline set of vital signs. Anything after there is a reassessment. The next step to do is to do your interventions. At this point, you've assessed the ABCs and most of the focus area based off your chief complaint. So you should know a general idea of what's going on with the patient, and so you should know what interventions you should do to treat this patient. For example, if it's chest pain and you have determined that it is cardiac related through your assessment, that's when you would administer a medication called aspirin to the patient. And we'll talk about that more in pharmacology and with cardiovascular emergencies. Also, this is where we have transport plans. Your primary assessment, you should identify if the patient is a high or a low priority. So if they are a high priority, you transport the patient immediately before you go into your secondary assessment. If you determine the patient is not a high priority, this is where we start our transport side of things after we finish our whole assessment and we have a good idea about what's going on with the patient. Again, if at any time your secondary assessment reveals that there's something more critical about the patient than you originally thought for your primary assessment, stop and go with transport immediately, then resume your secondary assessment on the way to the hospital. So let's take a minute and think about if you had someone who was complaining of shortness of breath, where would you focus your physical examination on? And obviously we'd want to have a really good look at the chest area, and we want to be listening to the lung sounds. We want to be making sure chest rise is going up and down and it's equal. All the things that we do to assure good ventilation. So that's where we really want to focus our physical exam versus focusing on something like maybe the abdominal area or your neurologic exam. These things are important to keep in the back of your head, but it's not what we want to focus on. So now that we've talked about our responsive medical patients, which are a lot easier to assess, we're going to talk a little bit about our unresponsive medical patients. So like we said earlier, our unresponsive medical patients, you have to rely a lot more on your physical exam and your assessment skills to tell you what's going on. You should start with doing your physical exam and getting your baseline set of vitals. Then we want to talk to family members usually, or possibly bystanders who may have seen what's happened, and try to figure out what type of medical history they have and what happened that made us get called. Did a bystander see a patient in the park sitting on a bench, then slowly go unresponsive? That could be a thing that happens when someone has a stroke. So try to gather as much information from the resources available as possible, but also rely a lot on your physical exam. Whenever someone's unresponsive, they are an unstable patient. So your entire assessment should be very rapid so that you can check as much as you can and check it very fast so we can identify and treat things that pop up to us. So when you're doing your rapid physical exam, you want to do what's called a head-to-toe physical exam. So you start at the head, you make your way all the way down. You want to be looking, listening, feeling to everything that you possibly can. It's very similar to what we do for our trauma patients. We go head to toe with our trauma patients, which we'll be talking about in a little bit. And you want to hit all the major areas. You want to hit your head, your neck, your chest, abdomen, pelvis, your arms, your legs, your back. Any part of the body you want to check, because any part of the body can cause some sort of medical issue. So when we're looking at our neck, some things you want to check for are jugular vein distension. Remember, we talked about that a little bit earlier in this chapter. That's when the jugular veins in the neck are bulging out. Usually it indicates that there's a backflow problem in the heart, so blood can't get into the heart as easily, so it backs up into your jugular veins. You're going to start seeing those pop out because they're so full of blood. Look for a medical necklace. Sometimes patients who have known medical problems, such as a seizure disorder or diabetes, will have that on a medic alert, either bracelet or necklace, so check for that. When you come to the chest, make sure that you feel the entire chest, make sure that you don't feel any broken ribs or anything like that, and then listen to your breath sounds. Abdomen, go and feel, see if it's distended, if it's firm, if it's rigid, if it's soft, if you have any response when you're pushing on there, because there might be pain. When you get to the pelvis, notice if they are incontinent of their urine or feces. That means if they can't hold it back, so if they have soiled themselves with feces or if they've urinated themselves, so know if that's happened. When you get to your extremities, check for a pulse. Make sure that there's blood flow getting down to your legs and down your entire arm. See if there's any movement or sensation. If you provide painful stimuli, do they respond to it in that area? Do they move it at all, depending on what type of stimuli they get? Check their oxygen saturation. This is where oxygen saturation becomes a bigger tool because they can't tell you that they're having a hard time breathing. And that some of the conscious controls that the body does to compensate for difficulty breathing aren't nearly as apparent. Again, check for your medical identification devices, such as a bracelet. Check your pupils when you get back up to your head. And really anything that stands out when you're scanning the body. Yeah, if you see anything that's not normal, that means investigate it further. So, like I said, we do a head-to-toe with our trauma patients. That's a little bit more in depth, especially feeling for things that may have been injured. This is more of a visual and a little bit of a feel and some listening to it. So it's similar in steps, but we do have different things that we do. So that's where we're going to cover that further in trauma assessment. Again, your baseline set of vitals. You should be looking for your pulse, respirations, skin condition, pupils, and blood pressure. Whenever you have an unresponsive patient, you should be requesting an ALS link, whether that's en route to the hospital or on the scene, depending on how close they are. When you have your ALS link, make sure that you have all the information available to you, especially a good baseline set of vital signs. That way the ALS provider can get a good picture as to what's going on with the patient, and they can start treating them a lot faster. Again, we're going to be talking to family members, or if no family members are available, talk to bystanders. If you can possibly try to find the patient's name, that's a good thing. That way we can identify them. Some patients will have ID in their pocket, usually in their wallet, especially if they are not at home. They'll typically have an ID somewhere. But ask what happened. Or if we go back to the park example, did you see them acting strange? Did you just find them unresponsive? Did you see them fine one moment and then unresponsive the next? Did you see any other things surrounding the incident? Did you see them using drugs? Did you see them kind of stumbling around beforehand? Did the patient have any complaints? Was he saying that he needed help and then you saw him go unresponsive? If you know the patient, does he have any known illnesses or problems? If you know the patient, are they taking any medications that you know about? And you can also look in your surroundings. If you're in a house, go ahead and look for medications. So a lot of people keep medications in the kitchen or in the bathroom. So go ahead and send someone to go look for that and see if they can find any medications that might give you a good clue as to what happened. One of the big ones is insulin. If you look into the fridge and you see that there's a bunch of insulin in there, that's a strong indication that this patient is diabetic. So we want to focus on our endocrine assessment a little bit more heavily. So use every tool at your disposal. Try to be adaptive, especially with unresponsive patients. You have to make do with what you have. So try to make that net a lot wider to get any tool that you can use to help you decide what's going on. Again, when we do our rapid assessment, we should be gathering things that will help us guide our interventions, and we should want to transport the patient. If they're unresponsive, like I said, they are a high priority patient no matter what. If they're unresponsive, so we should be doing our secondary assessment en route to the hospital. But that being said, take a couple of minutes to gather as much information and clues as you can, because just scooping up the patient and running and neglecting to see that they have a bunch of insulin in the fridge that might clue you in to do a more thorough endocrine assessment will be much more harmful to the patient. So taking the extra couple minutes to find out all the information you possibly can before you transport is appropriate at this stage. That way we can treat the patient more effectively. If they are in the park and no one knows them and you don't see anything around them and you have no clues what's happening, then yes, absolutely scoop them up, get the transport started immediately, because you've gathered all the information you can at that point. If they're at home, you might want to spend another minute or two just looking to make sure that we aren't missing anything. And remember, if needed, we should be immobilizing the patient's spine. So if you have any indication that the patient fell, then we should be immobilizing the patient's spine. So take a minute, think back. What other mechanisms might you have to obtain patient history other than speaking to bystanders? One of the big ones is medic alert bracelets or medical ID devices anywhere, and patients' medications, especially some patients, especially females, might be out and about, and in their purse, they'll have their medications. So medications are a big indication for what the patient's medical problem is. So combine all the resources that you possibly have to try to get some sort of picture of what's going on. Typically, between you gathering information and your assessment skills, you should be able to find out, for the most part, what's happening in an unresponsive patient. You won't always know, but you should have a good idea. So since this is such a long chapter, we're going to have a few stops for some mid-chapter review. So just a recap of one particular topic before we move on to the next, just because we do have a lot of content to cover today. So the secondary assessment of the medical patient takes two forms, depending on whether or not the patient is or is not responsive. So keep in mind, responsive patients, we're going to be relying a lot more on what they're telling us. Unresponsive patients, we need to rely a lot more on our physical head-to-toe exam. You assess the responsive patient by gaining a history of the present illness and the past medical history, then performing a physical exam of affected parts of the body before gaining baseline vital signs. Since unresponsive medical patients can't communicate, it is appropriate to start the assessment with a rapid physical exam. Baseline vital signs come next, and then you interview bystanders, family, and friends to get any history that can be obtained. As with everything in medicine, nothing's black and white. Adapt your assessment to the conditions you find. If family is screaming at you and telling you what's going on, don't say, oh, I need to do my head to toe first. Don't tell me anything until I do that. So if they're telling you the patient's diabetic, his blood sugar is low, take that information immediately and start your neuro exam to try to find, or your endocrine exam, my apologies, your endocrine exam to try to see if that might be one of the causes. Remember, patients can have more than one issue going on at once. So just because you identify the endocrine system needs assistance doesn't mean that you can neglect the rest of your patient assessment. So yes, it helps you focus in on an area, but that might not be the only area that needs help. So you still need to complete your exam, but having a clue as to what's going on quickly and being able to maybe delegate your partner to treat that area while you finish your exam is very helpful. So again, nothing or very little in medicine is black and white. A lot of it's gray, and this is one of those times where you have to be adaptive. So remember, you might not change any of your field treatment as a result of the information gathered during your secondary assessment, but the results of your assessment might be very important to emergency department staff or advanced life support if you end up linking up with them. So just because it doesn't directly affect your treatments that you're allowed to do doesn't mean that's not important to pass that information along so that higher levels can guide their care appropriately. All right, so moving on into the secondary assessment of the trauma patient. So this does differ from the medical patient quite a bit because we have to rely on our assessment skills much more higher. So think about unresponsive medical patients where we have to rely on our assessment skills more than the responsive medical patient. And the trauma patient, we have to rely on our assessment skills even that much more. So when we have a trauma patient, we have a wide array of injuries. You can have a minor injury, or you can have multiple severe injuries that could be life-threatening. So when we're looking at injuries, we should try to have a good idea of how serious it is. So some things that we quickly look at is the location of the injuries on the patient. If there's an injury to the foot, that's much less significant than an injury to the head or an injury to the chest. So if you have a patient who is shot in the foot, yes, they're going to be in a lot of pain, but it's not life-threatening. If you have someone who is shot in the head or the chest, that is most likely incredibly life-threatening and very serious. Another gauge is the patient's mental status. That will give you a decent idea as to how the body's doing. Again, if you have poor perfusion happening, or hypoperfusion, or shock, all these are pretty interchangeable terms, one of the first places that you're going to see that is in your mental status because your body or your brain needs so much oxygen to operate correctly. So if you have less oxygen, you're not going to be operating correctly with your brain. You're going to have altered mentation. So if you have altered mental status, that tells you that you have a compromise somewhere in your system that's causing this. So that will tell you very quickly whether or not you have a very serious or maybe a less serious injury. Anytime you see altered mental status, you have to think that there's a very serious injury happening. That being said, you could have a serious injury and have a fully alert and oriented patient. So just because they are alert and oriented does not mean that they don't have something serious going on. It's just a good indication if they're not, or if they don't have good mental status, that they do have a serious injury. Other things that you want to look at to determine how serious the injury is their airway status, their ABCs. Vital signs. Vital signs are, again, a outward representation of what's happening inward on the body. Look at your mechanism of injury. Mechanism of injury can give you a good idea as to what the body may have experienced. That's why we talked about and seen size of it. That's why it's one of the first things we look at. If you know that the patient fell from 30 feet, you know they have a high mechanism of injury, and we're probably going to be looking at internal injuries that we can't see, versus someone who fell from standing will have less of a chance of having severe injuries from that fall. Just because they have a less chance doesn't mean that they don't have it definitively. So that's why we still have to assess, treat, and transport these patients. Also look at the patient's age and pre-existing conditions. A mild trauma to a 20-year-old and the can be the same trauma to a 90-year-old. It would be much more significant because their body is not built to withstand mild traumas anymore. So a car accident going 15 miles an hour in your 20-year-old will affect your 90-year-old a whole lot more. So when we're looking at patients that have minor injuries or that we determine are low priority, these are ones that are alert and oriented and can talk to us. Typically, they can tell us where they're feeling pain. So an example of this would be someone who has a cut or a laceration to their forearm. Usually that's a one area complaint. So you can focus more on that area. You can say, okay, you have a cut here. I don't see any other trauma to your body on my quick scan. So let's treat this area and then make sure that you weren't harmed anywhere else. Another example would be someone who fell and they broke their leg. If it was a fall from standing or a fall from less than 20 feet, you can focus in and treat your leg after you do just a quick scan of the body, just to make sure that you don't see anything else that's injured. Then you can focus your treatment to that area, then go into your more detailed exam, make sure that nothing else is broken. So it works a lot more off of your chief complaint, and you want to conduct your history of present illness to find out how the injury occurred. That way you can make sure that you aren't missing anything else. For example, someone who fell and broke their leg, you need to find out, did you hit your head on the way down? Because they might just think, oh yeah, I've got a little bit of a headache, but I'm a lot more concerned about my broken leg because that's a lot more painful. But we don't want to neglect to assess and treat the head injury as well, just because we see a broken leg in front of us. So trauma patients that can talk to us and that are lower priority, we can focus in on the area that needs attention a little bit more quickly, versus higher priority patients, we have to assess the entire body first before we stop and treat. As you remember, chief complaint is what the patient tells you is wrong. And when you're getting a history of present illness on trauma patients, try to figure out what the nature of the force involved was. Was it a penetrating injury? Was it a blunt force injury? Try to find the direction and strength of that force. Find out if they're using any protective equipment, such as if they're in a car accident, did they have their seatbelt on? And that goes hand in hand with actions taken to prevent or minimize the injury. That would be having your seatbelt on, maybe an airbag deployed. And then find your areas of pain and injuries resulting from the incident. And again, in your physical examination, you can focus a little bit more on the injuries that you see in your chief complaint that the patient tells you. Keep in mind your mechanism of injury and think of what other injuries might be caused from a patient that has a mechanism of injury of this. Just because they're complaining about a certain area doesn't mean that they did not injure a secondary area. Again, our 3 techniques for physical exam are observations, what we can see, palpation, so what we can feel, and auscultation, what we can hear. So remember that term, look, listen, and feel. We want to be doing that to every area that we assess. When you're looking at your physical examination, you want to look at abnormalities and symmetry. So make sure that one leg looks like the other leg, or one arm looks like the other arm, or one side of the chest looks like the other side of the chest. If one side does not look like the other, find out why, because that's probably due to an injury. Look for color. See if you have bruising. See if you have any redness or any swelling, anything like that. Look for shape. That goes into swelling again. See if it's swollen. See if it's misshapen. If there's a deformity, you'll see that a lot in broken bones is deformities. And look for movement. See if it's moving normally or if it's moving abnormally. Is it an area that shouldn't normally move? That's a huge finding. So look to see what's normal and what might be different from a normal person. When you're palpating or feeling, you want to palpate for abnormalities in shape. You should know what things should normally feel like. Bones should be nice and straight typically. So if you palpate and you don't have a straight bone, that's a problem. Feel for temperature. Feel something's abnormally hot, abnormally cold, or feel about the right temperature. Feel for texture. So if you're pushing and you feel a texture and you start to hear a noise, that might be something called crepitus, which is the sound of or feel of a broken bone. And palpate for sensation. Do they have any tenderness to the area? Does it hurt when you push in on there? When you auscultate, you want to listen to lung sounds and breath sounds. Make sure that they aren't decreased or absent. This goes back into our airway management and our respiratory exam. You want to make sure that you have equal breath sounds on both sides. You want to make sure that you have good chest rise, which goes into palpation. But you want to make sure that both lungs are working equally and working effectively. So here is a acronym to help you remember your physical exam of what you're looking for in trauma patients. It's called DCAP BTLS. So that stands for a bunch of things that we want to be looking for. So the D stands for deformities and bones. C stands for contusions, which is bruising. A stands for abrasions, which is like a scrape. P stands for punctures or penetrations. B stands for burns. T stands for tenderness. L stands for lacerations or cuts. And S stands for swelling. So when we are listen, and feeling down the body, we want to be looking for all of these simultaneously. So we call it DCAP BTLS. That is what we want to be looking for to see if there's abnormalities in our trauma patients. After you do your head-to-toe physical exam, you then want to assess their baseline vital signs and try to get a past medical history. When you're getting your past medical history, try to use your sample mnemonic and ask any other pertinent questions while examining the patient. Reminder, your sample stands for signs and symptoms, allergies, medications, pertinent past history, last oral intake, and events leading up to the injury or illness. So, applying a cervical collar, that's how we maintain C-spine stabilization. This should actually happen in your scene size up. But if you miss it in your scene size up and then you're going down your rest of your assessment and you find that there is a need for it while you're doing your detailed exam, then put it on in your secondary assessment. So you want to be putting one on if your mechanism of injury, the history of present illness, or your signs or symptoms indicate that they might have some compromise to their cervical spine. You do have to make sure it's the correct size. And we're going to go over this in head, neck, and back trauma. So they're going to show you how to do it, but we're going to cover that in that segment of the class. All right, so you can go back and pause those slides if you really want to take a look at it. But again, we're going to be covering that more in head, neck, and back trauma. So when you have a trauma patient with a serious injury or multi-system trauma, multi-system trauma means trauma affecting several different body parts at once or body areas at once. So you might have a trauma that affects the head and the chest. So it's multi-system because you have your brain and your lungs and heart, so you're affecting multiple systems at the same time. So if they either have a serious injury of one area or multi-system trauma, they're usually going to be a high priority patient. So any high priority patient, you want to consider C-spine stabilization. And one of the reasons behind that, even if they don't have pain to that area, is if they've had such a significant traumatic event to affect multiple body areas or have a very serious injury to one area, they probably had enough force to compromise their neck at some point, and they might not feel that right away because they're focused on the major trauma happening. If you have your femur sticking out of your leg, you might ignore that little bit of neck pain that you have because you're worried about the bone sticking out of your leg. So have a high suspicion for C-spine injury and stabilize the C-spine as you deem appropriate. Also, you should be considering a request for advanced life support, just like with any other high priority patient. But as far as traumas go, ALS providers, yes, we can do some things to help, but what they really need is a hospital and a trauma surgeon typically. So do not delay transport just to wait for a paramedic. What we can do is very little compared to what a trauma surgeon can do. So that's what they really need. They really need to get to the hospital and get in front of a trauma surgeon. So we have what's called a rapid trauma assessment. Rapid trauma assessment is a quick exam from your head to toe to find out any injuries. This should only take a few moments in practice. When we are in class going through our practical exam, it's going to take a lot longer because you have to verbally tell your examiner what you are seeing, what you're doing. When you get into the actual field practice, a lot of this goes on in your head as you're coming down the body. So this should be very, very, very quick. This should be 15-30 seconds at the most. A quick head to toe rundown to find any major trauma that might be there. This should be performed initially at the scene, and then you should be reassessing it and maybe looking into more detail while you're on the way to the hospital. So just a quick scan on the scene, and then the rest of the care or assessment is done at the hospital or in the ambulance on the way to the hospital. So we, just like in our unresponsive medical patients, want to start the head, work our way down. We're going to be looking for a lot more detail though when we're doing our trauma assessment. So when you're looking at the head, you want to be feeling the cranium. You should remember where that is from anatomy and physiology. So feel the cranium, the face. You should look at the eyes. You should feel the ears, the nose, and the mouth. And you should also be looking at all this stuff. So just because you're feeling doesn't mean you can't look at it. You want to be looking for that DCAP BTLS that we mentioned earlier. If you see blood or clear fluid coming out of the nose or ears or mouth, that is a serious finding typically. That means that we have some sort of bleeding happening in our head. If we see clear fluid, that could probably be cerebral spinal fluid, which means we have a compromise in our neurologic system to the point where we have the fluid that's supposed to protect our brain and spinal cord leaking out. So that's a very serious finding if you see that. That's clear fluid typically. When we go to the neck, you want to look for your DCAP BTLS. You want to palpate, see if there's any tenderness. Look for your JVD, which is your jugular vein distension. You want to make note if the patient has a stoma or a tracheostomy. That's the surgical airway that's put in usually for people who have throat cancer. When we're looking at the chest, you want to palpate the chest, so feel it. Make sure that you don't see any DCAP BTLS. Make sure that you have equal chest rise. Chest is going up and down. And then you want to listen to the chest. So take a quick listen. Make sure you have lung sounds on both sides. Make sure that they sound relatively equal, that one's not really loud and one's really diminished. You want to apply your C-collar if indicated, which a lot of times it is. When you move down to the abdomen, you should feel to see if it's soft. Is there distension, which means it's pushing out against you? When you feel it, is there a pulsating mass that you're feeling? Which that's a very serious finding, which we'll talk about later in our trauma section. You want to gently press on all 4 areas, make sure that you don't see any abnormalities between the areas, or if the patient is conscious and able to complain of things, make sure that they don't have pain to one of the quadrants. When you go down to the pelvis, you want to feel the pelvis, so feel both sides, push down and in, make sure that you don't feel any crepitus, make sure there's not a significant amount of pain, make sure that feels stable in your hands, that's not moving around. You want to look for any bleeding coming out. You do want to check the genitalia on males for something called a priapism. Priapism is a erection that is a result from neurologic trauma. So if you have trauma to your spinal cord, you might see a priapism. So if you have an unresponsive patient with an erection, that's a male, that could be an indication they have a serious injury to their back. When you go down the extremities, feel for your DCAT BTLS. Then you want to make sure that you have pulses distally. So you want to feel for your radial pulse in your arms. You want to feel for your pedal pulse, which is found in your foot, for your lower extremities. That makes sure that there's no interruption in the arteries going to those areas. You also want to see if they have sensation and motor function to all those extremities. A lot easier to do in a responsive patient. An unresponsive patient, typically they won't have any sensation or motor function. You want to roll the patient and take a quick look at their posterior side. So feel down their spine, see if you feel any step-offs in the spine, anything that doesn't feel like it's in place. Take a look at their back, see if there's any bruising or any abrasions or bleeding or anything going on their back, which you can't see if they're laying down. So rolling them on their side and getting a quick look, you're going to see half the body that way. If you never roll your patient and take a look at their back, you miss half of your assessment. So if you end up using a backboard to transport the patient, which is appropriate in unresponsive patients, like we talked about in our lifting and moving lecture, when you roll the patient to put them on the backboard, that's when you can take a quick look and see all this stuff, then you roll them back onto the backboard. Again, once we do our rapid head to toe, so we just covered all those areas, you want to get your baseline vital signs and try to obtain your past medical history. Past medical history, it's nice if we know it, but it's not nearly as critical as in our medical assessment. So if someone can't tell you the past medical history, don't spend too much time on that. Yes, it is nice to know, especially if they have any like bleeding disorders or if they take medications such as blood thinners. It's definitely nice to know, but what's more important is treating the injuries that we see in front of us. So here's an example of a patient being log rolled to the side and the provider's looking and feeling down the back. So some general principles that we need to keep in mind. You want to communicate with your patient, especially if they're conscious. Tell them what you're doing. Don't just expose their body parts and start feeling them without telling them what you're going to do. So if you have a conscious patient, take a few seconds to talk with them. Remember to expose your areas before examining it. Take a look at the skin. See what the skin is telling you. If you have clothes on, it's really hard to see some injuries. So if you have a broken leg that you have baggy clothes over, you might not see that you have a deformity before you start feeling that area. So if you don't see it, you're going to feel pretty roughly going down, and you're going to cause a lot of pain to the patient and maybe some damage by moving some of the broken bone fragments while you're feeling down that area. Versus if you expose the area first and you see, oh, there's a deformity here, we can be much more careful in how we touch that area and how we move that area. When you talk to the patient, maintain eye contact, just like with any other patient that you're talking to. You should assume that there's a spinal injury until proven otherwise, especially if the patient has multiple other injuries. We can call those distracting injuries, and they distract both the patient and you. They can distract you because you look and you're like, oh, this is an injury I need to treat right away, and you forget to assess and treat other areas that could be injured. It's also distracting to the patient because, again, if you have a bone sticking out of your leg, that's going to be very painful. You're going to be focused on that because you can see it, and you won't be able to think about anything else. So your mild neck pain is going to be in the back of your head because you're distracted by thinking about that broken leg that you can see. So assume spinal injury until proven otherwise. And when you find anything that's wrong or abnormal, you can stop or you can alter your assessment process to provide care to that area. When we're assessing our extremities, again, you want to assess your distal circulation, sensation, and motor function. So circulation would be making sure you have a pulse. If it's in the arms, you want to make sure you have your radial pulses present. If it's in the legs, you want to make sure you have a pedal pulse present. You want to make sure that they can move their distal extremities. So if it's your arm, make sure they can wiggle their fingers. If it's your leg, make sure they can wiggle their toes or move their toes in one direction or another on your command. Make sure that they can feel. So if it's the arm, tell them to close their eyes and grab a finger. Grab such, like maybe your index finger, and say, what finger am I touching? Or you can touch the inside of their hand. Say, am I touching the inside or outside of your hand? Same thing with the foot. Am I touching the inside or the outside of your foot? Which side of the foot am I touching? Which toe am I grabbing? Make sure that they can tell you accurately what you're touching. That way you know that they have full sensation in that area. Right here, this is one of the areas you can check a pulse. It's right behind the ankle. You can also check a pulse in between the big toe and the second toe. So it's a very faint pulse. It takes a lot of practice to actually get, but that's an area that we do need to know how to get the pulse so we can assess circulation down to the legs. When it comes to pediatrics, keep in mind that they have much smaller bodies and things are a lot easier to damage. So lesser mechanisms of injury can cause significant damage to kids. And when you have kids, they're going to be scared. So this is where communication is very, very, very important. Tell them what you're doing so they aren't scared about what you're doing. So explain things very thoroughly to both them and to the parent. So take a moment and think, what criteria do you use to decide whether to perform a focused physical exam or a rapid trauma exam? And the criteria are things that we want to be looking at to decide, do they have a serious injury or multi-system trauma? So look at their mental status. Look at what you can easily see. Take a look at their chief complaint. Where's the location of their injury? So that will tell you a lot of what you need to know, and especially their mechanism of injury, especially if their mechanism of injury is not lining up with their chief complaint. So you need to think, oh, they might have a lot of other injuries because of their mechanism of injury that they aren't thinking about just because they have a distracting injury that they're complaining of. So moving on into our detailed physical exam. Your detailed physical exam is usually done on the way to the hospital. So this is after we've done our primary assessment and our secondary assessment, and we're trying to gather a little bit more additional information typically about how or the body system affected. This should be done after you do all of your critical interventions, and you should do this after your primary assessment is reevaluated. Again, primary assessment is something that we want to continually be reevaluating, but you want to do your primary, treat anything you find in there, do your secondary, treat anything in there, then reassess your primary, make sure it's still intact. So our trauma patients that we do our head-to-toe rapid trauma assessment, we have assessed every area. We've gone head-to-toe for a quick scan of the body. After we do that, we've stabilized anything we can stabilize, we've made sure our ABCs are intact, we can then revisit some of these areas and we can go more in depth. we can be a little bit slower, more methodical about assessing these areas. That way we can pick up on smaller things that probably aren't going to be life threats, but aren't easily picked up when you're just doing a very quick head-to-toe exam. Again, your initial head-to-toe exam in practice only takes a few seconds. So it's very, very quick and easy to miss some smaller things that might be going on. You might miss some small lacerations, some abrasion somewhere, things that might be harder to see that aren't in critical areas. So this is a time to revisit some of those areas and be a little bit more thorough on your exam. Remember, a detailed exam is only after all your critical interventions are done. If you have someone that is a critical patient and you are busy maintaining your ABCs or other high priority areas, it's okay if you don't get to your detailed physical exam. We want you to be treating the critical interventions first. If you can't get past treating the critical interventions because it takes up your time or it takes up your hands, then don't move on into the lesser stuff. Patients usually will survive if you miss something on their detailed physical exam. They won't survive if you miss something on their ABCs. So please prioritize yourself. Remember, when you're doing your detailed physical exam, expose your patient. We cannot fully assess something that we can't see. Sight is a huge sense that we have for our assessment. So get the clothes off, cut them off. You can work around immobilization equipment pretty darn well, especially if you're cutting clothes off. So again, like I said, we do our head to toe and we are taking a look and feel and listening to everything, but we're doing it very quickly to where we might miss the smaller stuff. So what we're doing is very similar to our rapid head to toe, but we want to do this slower and in more detail and more focus. And we can usually focus in on areas that we saw a concern of in our rapid head to toe. So when we have trauma patients that don't have serious injuries, this will be someone that, again, might have a laceration to their arm. They generally don't need your detailed physical exam. That being said, keep it in mind and remember that a lot of injuries to patients are distracting for them, so they might not tell you everything that you need to know. So don't neglect to do it just because you think that they have a minor injury, they didn't hurt anything else, they're not complaining or anything else. Make sure that you do a quick scan just to make sure that they haven't injured anything else. And also spend a little bit more time being aware of the patient's fear. A lot of patients aren't used to having traumatic injuries. So be there emotionally for your patients. Talk them through your treatments. Tell them that things might be okay. Don't lie to them if they aren't going to be okay. But if they have like a simple cut, say, oh yeah, this will bandage it up here. You might need some stitches at the hospital, but you should be okay. Be realistic with them. Try to be there emotionally for them. So is it necessary to always complete a detailed assessment on a trauma patient with no significant mechanism of injury? So no, it's not always necessary. Again, we should always do a quick scan of our patient. Sometimes that's more of a visual scan. If they are walking out to you and they walk with no difficulty, you can probably assume from your visualization that their legs are not broken. So you can assume a lot of your assessment based off what you initially see. And that quick 1-second scan of the body is pretty sufficient for a lot of your other systems that aren't affected. Just your quick scan saying, yep, that looks good. Sometimes a quick feel of some areas just to make sure is warranted, depends on the patient. But it's not always necessary to do a in-depth expose, look, listen, and feel to every body part if you have a patient that doesn't have a significant mechanism of injury and does not have a significant injury. So going into some more mid-chapter review, we'll cover some trauma stuff. The patient without a significant mechanism of injury receives a history of the present illness and physical exam focused on areas that the patient complains about and areas that you think may be injured based off of the mechanism of injury. After that, you want to gather a baseline set of vital signs and a past medical history using your sample mnemonic. For the patient with a significant injury or mechanism of injury, ensure continued manual stabilization of the head and neck. Consider whether to call advanced life support personnel if they're available, and get a brief history of the present illness, then perform your rapid head-to-toe trauma assessment. While you're doing your trauma assessment, look for wounds, tenderness, deformities, plus certain additional signs appropriate to the part being assessed. Look for your DCAP BTLS. Systematically examine the head, neck, chest, abdomen, pelvis, extremities, and posterior body. After assessing the neck, apply a cervical collar. If after completing the physical assessment, immobilize the patient to a spine board and get a baseline set of vital signs and a past medical history. After you've performed the appropriate critical interventions and begun transport, the patient may receive a detailed physical exam en route to the hospital. The detailed physical exam is very similar to the rapid trauma assessment, but there is a time to be more thorough in the assessment. The detailed physical exam does not take place before transport unless transport is delayed for some reason. The detailed physical exam is most appropriate for the trauma patient who is unresponsive or has a significant injury or unknown mechanism of injury. A responsive trauma patient with no significant injury or mechanism of injury will seldom require a detailed physical exam, especially of unaffected areas. Okay, moving on into your reassessment. So remember, everything we want to have our initial assessment, but that doesn't mean we can forget about it. We have to continually be reassessing our patients. So your reassessment continues on the initial steps. So you want to be doing your initial and then your reassessment. You're mainly looking for changes in the patient. So you want to see if your interventions are working. You want to see if your patient's getting worse. Is your patient getting better? Start to trend how the patient's doing. If the patient is worse on your first reassessment and then even more worse on your second reassessment, then you know that they are going downhill fast. Or maybe they are getting better on your first reassessment, then they got worse on your second. That means your treatment may have worked for a minute, but then it's not working anymore, so you might need to treat them further to have the desired effect. You can never skip your reassessment except when you are doing life-saving interventions. So again, your ABCs come first. If you are reassessing your primary and you see that there's a compromise in your ABCs, that's always stop and fix. So stop anything else that you're doing or that you plan to do, and you want to focus on that until it's resolved. So you can never skip your reassessment unless you are tied up in your ABCs again, and that is part of your reassessment. Again, we're looking for changes. Sometimes these changes can be very subtle, so we actually have to be doing our full assessment to catch them. Sometimes they are profound, like a change in mental status. That's a profound change. That's pretty easy to see usually. Look for your trends, whether they continue to get better, continue to get worse, or better than worse, or worse than better. You really want to pay attention if they are getting worse. That's called deterioration. If they're getting worse, find out why they're getting worse and what we can do to fix it. Again, communicate with your patient if they are conscious. You want to be telling them everything you're doing, especially if you continue to reassess areas that might be sensitive to them. Patients typically don't like being exposed, but if you have a trauma that you need to expose the skin and expose the body, you have to do that to fully assess your patient. That's the same on reassessment. You have to go back and look at these areas, see how they're doing. So you might do your initial assessment, cover your patient up with a blanket to keep them modest and keep them from not being embarrassed. But then you might have to remove the blanket and look at them again. So tell them, I have to check to make sure nothing's changed, so that they aren't thinking, why is my EMT keep on taking my blanket off and looking at my exposed body? Let them know what you're doing and why you're doing it. Again, your primary assessment, we have to continually be reassessing. A reassessment of a primary should only take a couple seconds, and it should be something that we are consciously always doing throughout the entire call. So making sure that they have their good mental status and their ABCs are intact is huge. And if you have a change, that will change your patient priority. When you're looking at pediatrics, if you have a pediatric patient that's unresponsive, when we need to give verbal stimulus, shout just like you would with a normal adult, and then painful stimulus, flick their feet, because that is usually a little bit of pain for them. And pediatrics don't tend to fake being unresponsive. Some adults might try to fake being unresponsive, so mild pain they might not respond to because they're trying not to respond to. Kids don't tend to fake this stuff. They don't know why they would want to fake this stuff. If you find that your patient is crying, that's a expected response from most children. That's them acting appropriately for their age a lot of times, especially our toddlers. Them crying, especially to a stranger or to an event happening that bothers them, is a normal response. So that's usually a sign that they have adequate mental status. One of the biggest parts of reassessment is reassessing your vital signs. So, like we talked about in the last chapter, you need to get your baseline vital signs and then repeat your vital signs so we can start to trend how the patient is doing. So, you want to be doing this every 5 minutes for an unstable patient and up to 15 minutes for a stable patient. So think of an example of a problem that might develop into a life threat to the patient on the way to the hospital. So this could be someone who has a head trauma and has a bleed going on inside of their head. Initially, they might be okay. You might not even see any signs or symptoms, but as blood starts to bleed out even more and put pressure inside of your skull, starts compressing on your brain, then the patient's going to start seeing some more altered mental status. Their pupils are probably not going to be equal anymore, might not be as reactive. You're going to start to see changes in your vital signs, and you're going to have a patient deteriorate and to the point where the pressure might start to affect the brainstem, and that will affect your heart rate, it will affect your respiratory drive, it affects your blood pressure. So that's something that someone might be okay initially, but on your reassessment, you notice that they start getting worse and worse and worse and worse. And that's because you have a bleed that's continuing to go on inside of your head. That's just one example of many that we could use of things that will make the patient deteriorate over time. So when you're repeating your assessment, go to the pertinent areas that you found on your initial assessment. So if you have a chest pain patient, start back at the chest and assessing your cardiovascular system. Keep in mind though, your chief complaint might change. It usually will change with severity. So you might have chest pain that went from a 3 out of 10 to now it's a 10 out of 10 because the heart's doing worse. Or you might have a change of location entirely. If you had someone who had chest pain, maybe now they have difficulty breathing that's started, and now that feels a lot worse than their chest pain. So that's now their new chief complaint. So keep in mind that your chief complaint might change location, but it could also change in severity, or it might change in both. Ask about changes in the symptoms to your primary areas that you were already looking at, especially if you were treating those areas. Find out, is that pain any better? Is it any worse? Did what you do have an effect on the patient? Make sure that you check what you did in your ABCs and make sure that that's holding. Make sure that your oxygen delivery, and if you're doing artificial ventilation, make sure that it's adequate, that it's still being delivered properly. If you controlled bleeding, make sure that that control has effectively stopped the bleeding and kept any new bleeding from starting in that area. And then look at any of your other interventions. Make sure that it's holding, that's doing its job, that nothing changed in it. So what's an example of an intervention that might need to be reevaluated, and how would you examine to know that it's being done properly? So a very easy one that sticks out are your ventilations. If you have to be using BVM to ventilate a patient, that's something that you have to constantly reevaluate, make sure it's being done effectively. So you want to look, listen, and feel for chest rise. Make sure that air is actually going into the lungs and that you have adequate chest rise and fall. So that's just one example of many different interventions that we need to be reassessing to make sure that it holds. Again, reassessment is not something you do once. This is something that we're doing multiple times during patient care. You want to make sure that you're trending how the patient's doing. You can only trend if you're doing this multiple times. Well, one of the biggest areas that we look for trends is in our vital signs. So find out, is the heart rate going up, 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 or low, 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 low? Find out what it's doing, especially with treatments that you render. Is it coming back down to normal, or is it still continuing to go in one direction or the other? When you see trends, that might show you that you need to do new treatments or you need to adjust what you're currently doing. So if you have a respiratory rate that is going up, 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 and up, and you're giving oxygen to the patient, you know that the pulmonary system is still working to try to fix something that's happening in it. So you might need to go from just oxygen delivery to change, and you might need to, one, up the amount of oxygen delivery, or two, take over ventilation of the patient. So trends are huge to help you guide the rest of your care. So as I've said a couple times now, the patient's condition will determine how often you reassess the patient. Unstable patients, we're looking at about every 5 minutes we are reassessing them. And stable patients, you can go up to every 15 minutes reassessing them. So if they're more critical, go ahead and assess them more frequently. Like I said earlier, and in our vital signs chapter, if there is any change in the patient's condition at any point, repeat your assessment, especially your primary assessment. So just because you assessed the patient 1 minute ago and suddenly there's a change to where the patient's not breathing, doesn't mean that you can wait 4 minutes to reassess, find, and treat that. If you notice that the patient has a sudden observable change, could be in mental status, could be in breathing, could be in circulation, could be anywhere. If you notice that they have an observable change, reassess immediately no matter what. So some more mid-chapter review. Reassessment is the last step of your patient assessment. You should reassess a stable patient at least every 15 minutes and an unstable patient at least every 5 minutes. When you're reassessing your patient, it should include reassessing your primary assessment, repeating your vital signs, repeating the pertinent parts of your history and physical exam, and checking your interventions, seeing how they're doing. Interventions you need to check include oxygen, bleeding, spinal mobilization, and splints. All right, so moving on into some critical thinking and decision making. So this is, we've done our assessment and we need to be making decisions on patient care. So let's talk about diagnosis for a second. Diagnosis is a label for a medical condition. there's a lot of debate in EMS about whether or not EMTs and paramedics can diagnose, or if diagnosis is something reserved only for doctors. This is a great debate, so I'm not going to tell you there's one right or wrong answer. Personally, I think that we provide treatments to patients based off of our assessment. If you are treating a patient, you are treating a condition that you find. If you find a condition and you identify that this is a condition and this is the treatment needed, that is what diagnosis is. So you are diagnosing the patient based off of your assessment. Sometimes that diagnosis might not be accurate. Sometimes it needs to change down the line. So that's why we call diagnosis a differential diagnosis, because that means that it can differ down the road. It's not your final end-all be-all diagnosis, but it is one that we are using to treat the patient with. So I like to say that EMTs and paramedics have differential diagnoses. So your diagnosis, like I said, comes from your assessment abilities. So that involves your physical ability to assess a patient, and then your intellectual ability to take that assessment, apply it to what you will learn in this class, and using the combination of those two, come up with an idea of what's going on with the patient and then how we can treat them. So when you think about getting a diagnosis, most people think immediately to doctors. You think about being in your doctor's office in a nice controlled environment, talking with your doctor, them doing tests and scans on you. Doctors have a lot more tools at their disposal and usually a lot more time in order to give a diagnosis. That's why doctors can give a final diagnosis of a patient. And oftentimes, doctors can be wrong in their final diagnosis of a patient. That's why people go and see second opinions, and sometimes their diagnosis will change. So even doctors who have been doing this for years and years and years can be wrong in their diagnosis. So us as EMTs and medics in the field that's not a controlled environment, and that we're working with very limited information, we have very limited tests that we can do to figure things out, we have very limited tools to effectively get a good diagnosis of the patient. That's why we do the working diagnosis or differential diagnosis, something that can change as we're presented with more information. And that's also why, just because we are thinking down one path doesn't mean that we shouldn't have further evaluation of the patient, because we don't have all the tools at our disposal in order to effectively diagnose a patient with a final condition. So you as an EMT are going to be a clinician. A clinician is someone who is working on a medical diagnosis of a patient. Clinicians have different levels of training. Doctors are clinicians, paramedics are clinicians, nurses are clinicians, you as an EMT will be a clinician. So vastly different levels of training, those different levels of experience, and like I said, have different technology and assessment tools at their fingertips. So because of that, techniques between clinicians will vary greatly. We have our technique is our patient assessment, and that's pretty much all we have at our disposal is our assessment tools, versus a doctor at a hospital might have a CT scan or an ultrasound or other forms of assessment abilities. We have our eyes, ears, and our vital signs. So we have very limited ability to diagnose the patient, which is why we have to be very, very, very good at assessing our patients, because we need to be very good at the limited tools that we have available to diagnose and then ultimately treat the patient. So traditionally, when you are diagnosing a patient, you assess the patient, and then you are given a list of different diagnoses that you can pick from. Your assessment should limit the diagnoses available to you. So if your assessment shows that the patient has altered mental status, they have cool, clammy skin, they have a history of diabetes and they have an insulin pump that's running, you then check your blood sugar level and your blood sugar is 32, your differential diagnosis should be limited very small to most likely a hypoglycemic episode or low blood sugar episode. That should have limited it down to that, and I can't think off the top of my head of any other options that might be. So your differential diagnosis should get limited down very small, but there are other cases where it might be much bigger, such as a chest pain patient. If you have a chest pain patient that you fully assess and they have 8 out of 10 chest pain in the left side of their chest that is not tender on palpation, that could be the heart, it could be the lungs. There's a chance it could be the musculoskeletal system. So that's where you have a few different other options available to you that you can't definitively pick from one. So you might have to treat all of them and see how the treatments do. So once you pick your differential, you treat your differential, see if it's gotten any better, and then reevaluate from there. So say you have your diabetic patient, you give them glucose, which again we'll talk about pharmacology, and they start to get better. That will help cement that that's most likely what's going on with the patient. If you give them glucose and nothing's changed in the patient's condition, they might have something else going on. They might have had low blood sugar, but they might also be having a stroke at the same time. So you have to then widen your differential because said, okay, well, I treated this one that I thought it was, and say their blood sugar came up to 80, which is a normal range, but you don't see a change in patient status. So that means that you have to widen your net to try to find out another differential diagnosis that might be going on in conjunction with the low blood sugar. Then after we do the treatments and we reevaluate, that will help us decide on our final diagnosis. Again, final diagnosis most likely is done by the doctor at the hospital just because they have more tools at their disposal to rule out other diagnoses. So when we look at emergency medicine, it is a little different than our traditional approach to diagnosis. So the goals of emergency medicine are to quickly rule out and treat immediate life threats so we can stabilize our patient for further assessment and care. That's our goal of our primary assessment, is to quickly rule out and treat the immediate life threats that we find. We then will return to gather additional information about the patient. That's our secondary assessment. And we need to be focused on our worst case scenarios. So we are trying to find and treat things that will be the worst possible case for the patient. That's why we take a good look at our C-spine in our trauma patients. A lot of times our C-spine is not compromised, but we take that precaution because it's our worst case scenario. If our C-spine is compromised, we cause even more damage to it. That can kill the patient. So we need to focus and rule out those worst cases before we move on to anything else. Emergency medicine, we're often responsible for multiple patients. If you have a called a mass casualty incident where you have multiple patients and not enough resources to take care of them, you have to manage multiple patients at the same time. Same thing in the emergency department. One doctor is responsible for many, many, many patients. You can't control the number of patients that come into your ER at once. So it's a little bit different than a primary care office where you have a one-on-one with your doctor. You schedule this visit so they can anticipate how many patients they're getting, and they can give you a lot of time. Emergency medicine, you might have multiple patients, and you have to prioritize who gets your time based off of their severity. Us as EMS providers, one of the biggest things we have to do is be very efficient. When an ambulance is taken out of service for one patient, they are out of service. You can't just magically take 5 more patients with you to the hospital. So the time that you spend with that patient, your community that you serve is going to be without your ambulance for that period of time. That being said, provide good care for your patient. That patient is yours. So don't rush through patient care and neglect to do something just to get back in service. But we do have to be efficient at what we do so that we can effectively provide patient care and then return to service so that we can provide for other patients. We also have a very uncontrolled environment. You have no idea what environment you're going to be working in. Doctors, primary care physicians, always are working in their office. Emergency care doctors are always working in the emergency room. We could be working in a back of a car one day. We could be working in someone's basement the other day. We could be working in the middle of the field another day. So we have a very uncontrolled environment. That being said, we also have limited tools at our disposal and we have a limited skill set. Like I said, we don't have CT scanners or ultrasounds or things like that. We have our assessment ability. We also are limited to the things that we carry on the ambulance. That's a finite amount of equipment. We don't have an entire hospital's worth of equipment. And when we're out of some equipment, we are out of it. We can't just ask for a supply tech to run up to the second floor and get us more gauze. If you run out of gauze, you are out of gauze. So you have to be very adaptive and good at prioritizing what we do. When it comes to diagnosis, like I said, we follow a lot of the same steps as physicians and especially emergency physicians. Most of our abilities are limited though, so we can't give full breadth of diagnoses. We have to work off of the ones that we can see and find on our assessments. We also, just like emergency medicine, we consider the most serious conditions with the patient. We have to think worst case scenario. And from our assessment and from thinking what are our worst case scenarios, that's where we get our differential diagnosis from. So think, you've reached a diagnosis, but you still have to treat the patient. Why? That's because our diagnosis can change over time. That's why we reassess, especially if we give treatments. We need to find out if those treatments were effective to see if our diagnosis was correct or if we have another thing that's going on with the patient. So you've heard me say it before. You're going to hear me say it several other times in the class. Experience matters a ton in medicine. I can teach you everything there is to know about the textbook when it comes to providing care. When you come out of class, you should have a lot of knowledge about being an EMT, but you don't know how to be an EMT yet. That's where experience comes into play. Experience teaches you how to do a lot of this stuff. I can give you as much book knowledge as I possibly can, but what really matters is getting the experience combined with the book knowledge. So you're going to see in the field that highly experienced clinicians might have some shortcuts that they follow. And they do this from seeing these types of patients over and over and over again. So shortcuts can definitely help because you can kind of limit your differential diagnosis a lot quicker and treat your patients a lot quicker. Shortcuts, however, come with their downfalls. There's a lot of people that get too focused because their experience says, oh, well, every single time I've seen a patient with this complaint, it's been this problem, so I'm just going to treat for this problem. And you might end up missing a secondary problem, or it might not be that problem this time. One of the biggest ones that I, as a paramedic, fall into is a pediatric patient with croup. Croup has a very distinctive barking cough to it that once you hear it, you can't unhear it. That's someone that I like to say I'll diagnose from 20 feet away as I'm walking up to the patient, because you hear that cough once before you even see the patient. Like, oh, that's croup. Yes, that experience helps me in most cases, but I can very easily say, oh, this is croup, I have to treat it this way, and not fully assess my patient to confirm that's croup. I can just go off of, oh, well, I heard this cough, it sounds like a croup cough, so I'm going to treat this patient like this. that can lead to very serious side effects because I might treat the patient ineffectively and give them the wrong medication to help them with their difficulty breathing problem. So yes, it does help a lot. Having experience helps a ton, but you have to, when you gather experience, you have to be aware that just because most patients present one way doesn't mean that that's exactly how your patient is presenting. So keep your full assessment in mind. You want to keep on doing it, and you want to use your full assessment to confirm that differential diagnosis that you got from your shortcuts. So keep all that in mind when you actually get into the field and are practicing. So when you're first starting out, there are some things that you can do to help think like someone with experience. First is love ambiguity. Ambiguity is being open to multiple different thoughts, multiple different pathways that we're going down. Be open to different things that you might not have thought about at first. Also, know that you are limited in your abilities. You know that your coworkers are limited in your abilities. We do not have the tools to assess everything. We just simply can't carry that type of equipment on an ambulance, which is why we have to rely on our physical assessment of patients that we do. So understand that we are limited. Know that you have to be adaptive. You can't just have one thing that works on most patients and apply that to every patient you see. You have to adapt to every single call, every single patient to find things that will work to complete the call effectively. And also keep on studying. We said this day one, and I'm not gonna stop saying it. Just because class is over doesn't mean that your learning's over. So keep on studying, keep on learning, widen your breadth of knowledge. The more knowledge you have, the better of a clinician you're going to be. Again, you have to be adaptive, change how you think, be very open and receptive to learn from others, whether that's a coworker, that could be another EMT, it could be a paramedic, it could be a nurse, it could be a doctor, it could be your patient. If you have a patient with a rare medical condition you've never heard of, ask them about it. Say, I've never heard of this, can you enlighten me so that next time I treat someone with it, I have a better idea. So learn from others, be a sponge that absorbs all the information you possibly can, and then reflect on it. Try to figure out, how am I going to apply this into my practice? So what are some of the important things to remember as you learn how to make a diagnosis and improve your critical thinking skills in EMS? One of the biggest things is know that your first diagnosis might not be accurate. Be okay with that. Know that your diagnosis can change when you are presented with more information. And also know that we don't have all the tools at our disposal to make a full and firm final diagnosis. All right, moving on to chapter review. EMTs make some diagnoses in the field, although they are not as extensive or detailed as physicians' diagnoses. The traditional approach to reaching a diagnosis is to assess the patient, draw up a list of differential diagnoses, assess further to rule in or rule out the different conditions, and narrow the list until you reached a conclusion. Highly experienced physicians don't always use the traditional approach. They use shortcuts in combination with their experience and training, which speeds up the process of reaching a diagnosis. Learn to think more critically by accepting the ambiguity of EMS working conditions, understanding limitations of people and technology, forming a strong foundation of knowledge, and organizing the data in your mind. When considering the cause of a patient's condition, don't let your search for a cause delay your treatment of the patient. Keep in mind, use your mechanism of injury to determine the need for a rapid trauma assessment. Always assume spinal injury until proven otherwise. Work as a team to complete your assessment. Some questions to think about. How do the focused physical exam of a trauma patient with a significant mechanism of injury differ from those for a trauma patient with no significant mechanism of injury? Again, if you have a significant mechanism of injury, you want to be doing a rapid head-to-toe assessment. If it's not significant and you don't see any major injuries, you can focus in on that one area that's injured. List the steps and areas covered in the rapid trauma assessment. How are these steps different in the detailed assessment? So we're going to be doing this in class over and over and over and over again. So we'll list all those steps in class. Just because you missed one class doesn't mean that we won't be doing this dozens of times. The steps of a rapid trauma assessment are a little different because we are doing it very quickly. And then when we get to our detailed assessment, we're focusing in and taking a closer look on things. So the steps are similar. We're just taking a closer look in our detailed assessment. You're assessing a patient who fell 3 stories. He is unresponsive and bleeding into his airway. The driver of the ambulance is positioning the vehicle and bringing equipment to you. How do you balance a patient's need for airway control, he requires frequent suctioning, with his need to assess his injuries? So if you are the only provider able to do assessment and do interventions, so if your partner is just a driver, is not certified at any EMT level, then you are stuck at your airway suctioning until you have more help and more hands. ABCs in your primary assessment always come first. Secondary assessment is something that we should get done, but if you can't get past your primary assessment, you can't get past it. So always keep that in mind. Your primary assessment comes first. Secondary assessment's great, but you can assess your patient as much as you want. If you ignore treating something in your primary assessment, you're not going to have an alive patient for much longer. So the best assessment in the world means nothing if your patient's dead. So primary assessment always comes first. All right, and that brings us to the end of this chapter. Like I said, I know this is a lengthy one. This has a lot of content in it. Feel free to skip around to look at any other thing that you might not be fully firm on. And until then, we'll see you next time.